Welcome, and thank you for joining us for our live virtual MDA Engaged Community Education Seminar, where we are highlighting specialists in the South today. I'm Nicole Petrowski. I'm MDA's Community Education Specialist, and we appreciate you joining us virtually today. We're committed to community education, and we believe in the power of bringing community together through opportunities to learn from specialists and having opportunities to connect with others. So thank you very much for joining us today. Our community education seminars, which is what we are having today, is geared toward general neuromuscular topics. While each event features regional specialists covering these topics, each event will also feature specialty topics, which you can view on the screen. These are the events that we have lined up for the remainder of 2020. And as you can see, our last disease-specific symposium is our SMA symposium on November 14th. Some of you might remember our MDA Telethon with Jerry Lewis from years ago. Well, we're very excited to relaunch this legendary Jerry Lewis MDA Telethon with Kevin Hart joining as host. The telethon will be a 2-hour special airing globally on Saturday, October 24th at 8 p.m. Eastern on LOL Network. Hart will be joined by celebrity guests including Jack Black, Usain Bolt, David Levy, Michael B. Jordan, Eva Longoria, and more. And funds received from this telethon will support all the work MDA does for all of our 43 neuromuscular diseases that are under our umbrella. And to learn more about this big day and to join us, please visit thetelethon.org to learn more. Also, we would not be able to put on our educational programs without support of our generous sponsors. So I would like to thank Numotion Foundation, Biogen, and Genentech, as well as all of their representatives that are in attendance today. So thank you very much for your support. And I have just a few housekeeping items to go over before we begin our seminar today. We are recording today's events, and we will be posting it to the mda.org website for on-demand viewing in a few weeks to ensure that those who weren't able to join us today can watch it later. Also, all phone lines have been muted, and we will be having a Q&A session at the end of each presentation. So please utilize the Q&A icon at the bottom of your screen to type in all of your questions that come up. You can just send those to host, and you don't need to wait when the presentations are over to submit. You can submit your questions while the talk is being talked about, and that way we can kind of field through those as we get them. We also encourage participants to communicate with each other by utilizing the chat feature throughout the day. If you want to just say hi or let participants know where you're from, or tell a little bit of your story, just simply click on that chat icon at the bottom of your screen and make sure you submit to all panelists and attendees so the attendees can see your comments. And you'll also notice on the agenda here that there are a few small breaks in between some speakers, so feel free to stay connected, or you can hop away to get something to drink or to eat. That is my time to get the folks set up for the next session. So I will be checking their audio and you will be hearing us. So I do know that. We just need to make sure that their audio and video is working before they present. So that's what those little breaks are for. And then finally, we will be sending out a brief survey at the end. We would like to receive your feedback on what you've heard today. We take your comments and feedback to heart, and we want to make sure that the programming that we're doing is what our patients want to hear. So your feedback is really important to us to plan for our 2021 series. And with that, I'm going to turn it over to Dr. Amanda Witt. She is the Associate Professor and Division Chief at the School of Medicine, Department of Neurology, as well as the MDA Care Center Director at University of Mississippi Medical Center. She did her residency at Baylor University Medical Center and her fellowship at University of California, Davis Medical Center. So Dr. Witt, I will turn it over to you and you can share your screen.
All right, it looks like it's sharing. Is that accurate?
It is. If you could just turn on your video.
All righty. There we go. Okay, so good morning, everyone. Thank you for joining us on a Saturday morning. I know it's not quite like we envisioned several months ago, but we're keeping everyone safe, and you can be in your pajamas and no one will care this morning, so there are benefits. Let's see. There we go. So I'm basically going to discuss how we structure our clinic, and this is pretty standard. I know every MDA clinic is a little different based on where they are and where they have funding. The MDA does allow us to have extra personnel in clinic and make it as easy as possible for our patients to come in and be able to have several services within the same clinic, so you don't have to travel back and forth. As you know, they're not MDA clinics on every street corner, and so a lot of our patients do travel, and the more convenient we can make it, the better. So we'll talk about the clinic, what we can focus on with patients in the clinic, how we transition from pediatric to adulthood, and then into the geriatric population. And then I'm going to go over some new treatment options we have available to our patients, because I think that has been becoming, thankfully, more and more important as we transition into a period where we have treatment options for patients with genetic diseases and disorders that we haven't had treatments for way too long of a time. So why is the MDA a multidisciplinary clinic? And as you all know, especially our patients know, Muscular Dystrophy Association doesn't just see patients with muscle problems. When you have muscle weakness, yes, we can help you with exercise programs and diagnosis and making sure you have little tricks and gadgets and equipment for that muscle weakness, yes. But the muscle weakness doesn't just affect your skeletal muscles. It can cause cardiac complications, not with everyone, but with a certain subset of diseases. We need to make sure we're monitoring that closely. Sometimes that means the heart muscle is weak. Sometimes that means that the electrical conduction from the muscle to muscle in the heart doesn't quite go as planned. There are muscles in our gut, and so not just skeletal muscles, but the smooth muscles that help get food out of our stomach and through our gut can get slowed. They can have a lot of trouble for that. We can do medications for it, get you into the right specialist for it, that sort of thing. Sometimes diet is important, depending on the diagnosis. There are eye complications, sorry that wrapped around, with some of the disorders, and so we can help you find the right person and the right, just to know what to look for, kind of discuss some of the symptoms that you can monitor for, and then we can get you to the right specialist. The lungs typically are fine. So getting oxygen from the lungs and that tissue can be beautifully normal, but the muscles play an important role in getting the lungs to expand and contract and really get that airflow going and moving. And so that can get impaired, especially at nighttime. And so we monitor that in our clinic. We actually have a machine to help monitor the muscle strength of the lungs in clinic. And then we also have specialists we can connect you with. Mr. Bones here reminds us that obviously if you have muscle trouble and the muscles aren't moving the joints don't like that very much and they can get stiff and contracted. Scoliosis is also a big issue in a lot of our patient population. So we have to remember to take care of that system. What I haven't mentioned there, but we have to remember is also if you're not getting up and moving and the muscles are weaker, the bones can get thinner. And so we have to monitor those and think about bone health and get scans to make sure the bone density is okay, maybe do medications to build up bones. And then the swallow, of course, is very important. It can get weak with the rest of the muscles. It can spasm sometimes in certain disorders such as myotonic muscular dystrophy, so that food sticks instead, not from weakness, but from a spasm. And then weight is always an issue in our human existence, but especially if you're not very mobile, and sometimes that's not enough weight, and sometimes it's hard to exercise and get off the weight, and so nutrition plays an important role. If you have a gene that means that you metabolize sugars or fats a little differently, then we need to discuss diet and how to target where you can get the most energy out of in your diet as well. One thing I didn't mention, it's not global, but we do have to think about endocrine issues. Some of our Duchenne muscular dystrophy boys do have a delayed puberty. If they don't have the testosterone, then that can contribute to the bone thinning. Some of our patients are high risk for diabetes or thyroid disease, and so we do have to monitor that as well. So we do have our clinics divided on Tuesday mornings. We have 3 Tuesday mornings a month where we do have pediatric and adult clinics. We try to get all the kids on the 3rd Tuesday, but if their parents want to come and their patients too, then we mix up a little bit. And then the 4th Tuesday morning is a multidisciplinary ALS clinic. So our ALS clinic, we have been able to gather in some additional support. So in every clinic, we do have physical therapy. We have an equipment representative, excuse me, who can help with measurements and wheelchairs and Hoyer lifts and hospital beds and all kinds of things. As discussed, we have the pulmonary function testing, little handheld device, which helps. I have asthma, and let me tell you, those full pulmonary function testings that you have to go to take 2 hours to give you a migraine, and it costs about $400, and ours we can slip right in. We have a social worker available. We have now 3 neuromuscular physicians, myself, Dr. Shukla, who you will hear from later, and then our newest addition is Dr. Tiffany Pike Lee. We're very excited about. She's from Cleveland Clinic and has been a lovely addition. We have a nurse practitioner, Miss Beverly Spicer. Some of you have seen her. And we always have toys for the children. So that's very important. We make sure of that. Then on the ALS clinic, we additionally have a speech therapist who specializes in ALS and is very enthusiastic about all the care that we can give our patients. And that includes actual swallow, actual speaking as well. And so they can get assistive communication devices and help plan the progression with the swallow decline. We have a nutritionist who has been there several years, and we have a respiratory therapist who does some a little additional testing and advisement as far as equipment goes. And then sometimes we'll have a respiratory vendor there as well who can help set any patient up who needs it, like a BiPAP or a sleep apnea machine. We do see all ages in our clinic. I'm very fortunate that I have been trained to see all ages. I love the few days old to patients in their 90s. It's just a privilege to be able to see everyone and not to have to transition our patients out of our clinic into an adult clinic. We can just see them all. Beverly Spicer and I typically see the young ones, and then our other 2 can see 16 and up, although it's not a hard and fast rule, mainly because I don't like to give up seeing anybody that I usually see in clinic, much less the little babies. So I have to share. Then we move into adolescence. And as we move into adolescence, a lot of the goal is, even though we're still going to be seeing these patients and taking care of these patients, is to still have a transition where we give them more opportunities to discuss their own treatment and to give us ideas and to question things themselves and to come up with ideas they may need for their own equipment. They're keeping up with their medications. They're keeping up with their specialty appointments. Maybe not calling and making the appointments yet, but still being more active in a role in a management and independent with their own medical care, which is a very important part of development and growth. And then as we move into young adulthood in the 20s, then we really want them taking ownership of making the appointments and seeing those specialists and calling the vendor when they need something, instead of mom and dad still doing that, if at all possible. And then, of course, we see the spectrum of adulthood and discuss work and sometimes disability and childbearing and family and all those lovely things that happen in adulthood. And sometimes even helping them take care of their other family members and their older family members. We've had that quite a bit as well, and how to manage that with a disability. And then we move on into the older adults. Sometimes there are diseases specific to our more geriatric population. Sometimes it's just an ongoing process through life, and then we battle other things. We battle other excuse me, other health issues as patients get older that then we have to integrate into our care for their muscular dystrophy or neuropathy or whatever. And sometimes it is a new a new process. Some muscular dystrophies don't occur until later. Inclusion body myopathy tends to be in a later age. And so we have to remember that what I advise them with their muscle weakness is going to be quite different from what I advise a younger person. Now, one of the most rewarding things we've had, of course, I love seeing patients and giving them all kind of tricks and gadgets and advice and help, and just listening to their struggles on a day-to-day basis and trying to do some problem solving for each person. But now we also, in addition to all those things to go into taking care of patients, we actually have genetic treatments. And some other, ALS doesn't have genetics yet, but it does have some other treatments available that we can recommend. And so it's a whole new world for a couple of our disorders. Now, if you do not see your condition listed here, please don't be discouraged, because any new advancement for any one of our diseases, any process really, can then be translated into other diseases. So we're borrowing already in research some of the CRISPR-9 treatment from the sickle cell world, and we're going to move it into our world. And so we certainly can build on these things for many more patients. And so any step ahead, any research for one disease is really for all of them, although I know it can be very frustrating. It's very frustrating on my end, and that certainly is nothing compared to someone who has to live and wait for a treatment day to day. But here is what we have right now. For Duchenne's spinal muscular atrophy and ALS, I know that Dr. Shukla is going to go into more detail with some of the research, but I want to give you an overview since we're talking about what we can do in a clinic setting. One of the things is to discuss treatment options, to discuss research, to discuss things that may not be FDA approved yet, that may be available but not proven. We can talk about things and what may or may not be appropriate for a patient. So in Duchenne muscular dystrophy, the problem is that you're missing a protein that stabilizes the muscle membrane. And if those proteins that stabilize the membrane are really key in making sure the muscle can recover from damage. And so muscles all the time get broken down and built back up, broken down and built back up, just like a lot of our cells in our body. That's how we gain muscle. That's how we grow muscle when we exercise and lift weights. But if you don't have that stabilizing complex that helps your muscle recover from damage, then those muscles break down and the cells die and you lose muscle over time. One of the biggest anchors of that protein complex is something called dystrophin. It is very big. It's one of the largest proteins in the body. And this is the code. This is the gene code for that protein. So we look at it like this, and I like this diagram because you can see how all the little pieces of the puzzle fit together to make the long protein. One of the things that has been in the last 20 years is we've understood why some patients who are missing just one little link of this, even less than this, even just one little piece of this bigger piece, can have Duchenne's. And why some patients can miss like all of this row and all of this row and half of this row and have Becker's, which is the less severe form of Duchenne's, where they do make some of that dystrophin protein, just not enough to be completely asymptomatic. So that hasn't made sense until we understood how these things link together. And once we understood how they link together, then we've been able to make a treatment for it. So I say we, in the broadest sense of the term, I'm very clinical. So let's say you're missing all of these little links in the protein, which is a good deal of it. But look how this one can still link to this one. Flat links to flat, and it'll make a protein out of this jumble, even with that huge section missing. As opposed to Duchenne muscular dystrophy, where you can be missing just a couple of these pieces. But this link will not link to this one. And so you can't make a protein. And so nothing gets made. But this is what exon skipping does. So exon skipping is the therapy we have for Duchenne. Every one of these blocks is called an exon. And so ironically, what we can do, instead of putting these back in order, which would be very complicated and difficult, we can actually take another one out. So we have a weekly infusion. The infusion goes in, it binds specifically to this exon, taking it out of circulation too. It makes sure that that is not translated into a protein. It is not read out to make a protein. And so this guy can fit with this guy and actually make a protein. It's not perfect. It's like Becker's, where you have a protein. It may be broken down a little more easily. It may be a little more fragile, but it works. It is actually present in the body and can help with muscle strength. And so that's why they call it skipping. It jumps over it and actually makes a protein. We have had several there's 3 medications for 3 specific different exons available right now. There are 3,000 mutations that can occur in this one protein, and so we are not perfect by any means. We are not being able to treat all Duchenne patients by any means, unfortunately. Many of our patients will be able to use this technology as they come out with different medicines to be able to skip over these exons. Some patients just have one little piece missing from the exon, and I think that will be more amenable to the CRISPR-Cas9 therapy, which is being researched right now. And so everything is so much closer than it has been. This was a theory in an experiment when I was in fellowship in 2010. And so now 10 years later, we have 3 medications and more coming to be a reality. And so I think we're around there with CRISPR-Cas9, and I think we're closer to that becoming a reality as well. So spinal muscular atrophy, that picture got bigger when I said it, I'm sorry. But that's okay, because this is the main thing I want you to see. Yeah, you can move my face so you can see it. So spinal muscular atrophy is another one. In 2017, when we now have a treatment. SMA is a lot easier than Duchenne because it's one mutation. Even though you have patients that are very, very weak and present just a few days old. And then you have patients that are maybe in their 30s and 40s and present with weakness in their hips and their shoulders. And then you find out that they have SMA. All of those patients have one mutation. They are missing this protein. Now, this protein is survival motor neuron 1. There's a lot of abbreviations in this one. I'm sorry for that are very similar. But this is a big protein. It bathes in the spinal cerebral fluid. It gets around those motor nerves, where the motor nerves start. They go all the way out to our muscles, and it has a protective function. When it is missing, the nerves aren't as protected. They're more likely to die and degenerate, and that is what we see happen. Now, even without this protein, then we still have a smaller protein, and it is called survival motor neuron 2. The difference being this one little bit of the whole protein here is that this guy always gets included when you're making the big protein. This little link, just like we saw in Duchenne's, this little link that gives the code to make the protein is always included. On this guy, about 75% of the time, it gets skipped. And so what you wind up with is a very short protein that's easily broken down. And so it doesn't protect as well as the big guy, although it certainly helps. Occasionally, it will get made into the longer protein. We'll include 7. It gets made into the longer one, and it sticks around a little better. The more of this patients with SMA have, remember, this is always missing. The more of this they have, though, the more protected their nerves are, and the less weak they are. So the longer they can walk, the longer they can have muscle strength, and so forth. So that's the difference in the spectrum you see with spinal muscular atrophy. What the new medications do, there are 2 medications now that will do this. One is put directly into the spinal fluid, and it's called Spinraza, and one is an oral medication that is brand new, like within 6 weeks old. And they both go in to make sure that this exon is included when you're making a protein. And so that you're making this big guy a lot more than a little bitty puny And so that protective function gets enhanced in these patients, and they can get stronger and breathe better and have fewer respiratory infections in the winter and have better muscle strength. If you start this really, really early on in the infants, um, they can have almost no symptoms. Like very severe ones will still have some symptoms, but you take ones that would have been able to sit and have a good life expectancy, they can just really, we've had some milestones as an infant with these medications, with Spinraza specifically. So it really does have a big impact, but even our older patients have benefited either from not declining or having fewer respiratory infections or having a little more hand and trunk function. We've seen some pretty significant gains. This one's a little newer, but they've had good evidence in trial that they will do similar, have similar improvements. There's one replacement gene medication. It's called Zolgensma. Genetic SMA is how I remember that one. It is a one-time infusion for children under 2. Right now, it is primarily for SMA 1, but really any infant under 2 that has significant symptoms is a candidate. And it basically replaces this gene. So that is also fairly new. I think it's been out for a year. I've seen some great benefits, and it varies. What we're trying to work with insurance is that we might be able to have options past Zolgensma for the ones that are a little more severe and don't respond as well. But it's still a wonderful opportunity, and especially because it's only a one-time infusion, and the rest you have to be on a regular basis. And so that is very appealing. But look at all that we've had in just 3 years. Just 3 years, all of these have been available to help. Now, ALS has been a challenging disease to find a treatment for because it's such a complicated illness. By the time you have symptoms with ALS, you've already lost many, many, many motor neurons. And so we always start behind the 8 ball when we're trying to treat ALS because we don't have a way to diagnose it early right now. And that's because, you know, we only have gene markers in maybe 10-15% of patients. And not everybody with a gene is going to have ALS. And so you can't treat everybody with the gene. Sometimes it's a toxic influence. Sometimes it's a repeated trauma influence. And so we really think ALS is something that happens not because of one reason or one cause, but several causes that have a similar pattern of illness. And that makes it very complicated. One of my fellow colleagues had said, and I think this is very, very true and very explanatory, said it's like it's like having a car with flat tires and 3 of the 4 are flat and trying to put air in the 4th tire to treat ALS. And so it is a challenge. And that's why we don't have a genetic treatment right now for ALS that's so pretty and elegant as the other 2 diseases. Number 1, it really wouldn't help all patients. And number 2, it's not a perfect correlation between having the gene and getting the disease. There are a lot of trials ongoing, and I've heard them for years about looking for markers in the spinal fluid, trying to come up with some screening test to look at people who have risk and catch it earlier. We just haven't been able to get there yet. But we do have a couple of options for ALS. Both of these are to try to cut down on inflammation and radical scavengers and basically degeneration of the nerves once they're sick. Riluzole we'll jump down to first. It's been around for many years, as long as I've been in practice. It's an oral daily medication. It's actually twice a day. It's been shown in studies to slow the decline of function, and it improves survival by about 2 to 3 months, at least ventilator-free survival by 2 to 3 months. The ultimate treatment you could have for ALS, our management strategy, would be a ventilator, and those patients on ventilators live several years. That kind of takes away the pressing issue of respiratory decline, which is the ultimate cause of death in these patients. It's pretty well tolerated. I've seen some GI side effects, maybe a little upset stomach, a little diarrhea from the riluzole, but overall it's very well tolerated. It isn't a daily medication, it's oral, and so it's not too challenging. The cost is fairly reasonable with most insurances. Occasionally we'll run across one that causes us trouble. Radicava is a newer medication. It's been out, I think, again, 3 years. 2017 was a banner year for neuromuscular disorders. It is an infusion. It is given every day for 14 days, and then you're off for 10 and on for 14. And it's supposed to be for 1 year. These trials were not done in the United States. They were done in Japan, which is a little different with the regulatory body. It actually took them 3 tries to show any benefit. What they had to do with each trial, so they started with a lot of ALS patients with varying degrees of severity of illness. And so some couldn't walk, and some had a little more trouble breathing, and some had trouble swallowing. They took the whole group, and they didn't show any benefit with the medication. And then they narrowed it down to a smaller criteria. So they got patients that were a little less severe, and they did it again, and they still didn't see any benefit. And so then they really narrowed it down to patients who were ambulatory only with lung function on our measurements that was greater than 80%. And those showed some slow decline. The frustrating thing about both these medications is that you will not see improvement with either of them. It's a theoretical slow decline. And so unless you have one person, you duplicate yourself and one person's on this treatment and one person is not, you won't be able to know what the difference would be on them. I've had a few patients on this medication. I think the ultimate frustration is that you're on this infusion and putting in so much effort to not see any significant improvement. But the combination has been shown in that trial with patients if you can catch early enough to slow the decline a little more. We do have several promising trials in progress. I've been looking at them with patients. Some of those medications are commercially available, some are not. And so we just watch and see what we might be able to do in the future. There's stem cell trials have been in progress for several years with ALS in varying degrees of success. I have not seen one come out to be significant and really make it past the second stage of research. And that's pretty important. Stem cells can be risky. The ones they're doing are implanted directly in the spinal cord, and so it's pretty invasive. And so we want to see good success before we start recommending that to patients. I would say in any research trial, in general, if you're a patient and you're looking at trials, you can go to clinicaltrials.gov.gov, type in your illness, see which ones are up there. Sometimes they're enrolling. All you have to do is contact the study manager if you're interested. I know in the Southeast it's hard to get onto some of those trials that are close by, but occasionally you'll get lucky and one might be in Houston or Florida and can really help you. And so I'd always recommend my patients go on there if they're looking for trials. If you're just looking at trials to see which ones might be closer to being a reality, I would look for a phase 3, because that means they're actually testing it on patients to see if it works. Phases 1 and 2 are a lot to do with safety, okay? And you might not want to get on one of those. Once they know it's safe and they kind of know the dose, then they'll look for efficacy in a trial that's phase 3. And so, you know, if it says a 3, it might be a little closer to reality. Once you see something come out, I would see how many patients were in the trial and what side effects they had. I would be very, very cautious for doing anything outside of the country. We have pretty strict regulations from the FDA here in the country. I know that is a mixed blessing. Sometimes it can be very frustrating. Sometimes things move slower than we want them to move. But we do have some safety net in there for patients that aren't there. Out of the country, I've seen patients go do stem cell in Israel and Mexico and other countries, pay $40,000 and get worse. So we just have to be careful out of the country for things that sound so wonderful, but they really aren't regulated and they really aren't using technology that is ready to be used. all the time. So I will just be careful, be smart, but follow those trials. We're following them, and we are always happy to discuss and think through options for any disorder, especially something that may not be high risk, but may be helpful. We can look at supplements. I mean, we can think through what might be best for any one person. So I get this not infrequently, is why really come to our clinic? Why really make the drive, make the effort, come see us, maybe see me, maybe see Dr. Shukla, depending on who gets to your room first, if we don't have a treatment for your illness. Well, for one thing, we're always here. We're here, we're ready to listen, we're ready to discuss your life and how we might be able to help you with energy conservation, exercise, diet, strategies, equipment, anything to help you live your best life, be as independent as possible, and do the things that are critically important for you. In a way that I think physicians, internists, family medicine, as lovely and as helpful as they are in so many ways, don't have the experience with. That's just not their specialty. I do think everyone needs a good primary care provider, internist, family medicine, whatever in your area, to help you when you get sick, or to help your blood pressure and do all the regular screenings. Our patients are people and they have all the regular health concerns too. Please go see your primary doctor. But I think we can help you in a way and think in a way that is a little unusual and a little more suited to our patient population, which we should be ashamed if we couldn't. We can also get you in contact with people who can help you. I think some people, and I think doctors are bad about this. They see one thing on your list, and that could be a muscular dystrophy or Charcot-Marie tooth or ALS or anything that kind of stands out, and they tend to connect anything that goes on with you with that disease. And it's really a shame, because you have things that come on. You have back pain and maybe a disc bulge that can be helped with pain management, a steroid injection, that they may just say is your muscular dystrophy. And so you do have to think out the box. You do have to realize you come into us with all the mix and all the different influences and problems that we all have. And we can always treat those as they need to be treated, whether you have a muscular dystrophy or not. And so we can help you see past that and figure out what is just going to kind of be expected and what we need to actually target and treat. And I think that's a little easier for us because we see we specialize in these things. We specialize in what is the disorder and what isn't. We can keep our pulse on therapies and upcoming therapies with you, discuss it with you. We're going to the MDA conferences, well, we usually do, whether it's virtual or in person, that help us connect with these researchers and be able to sit at the table with these researchers and actually have exposure to them, and then bring that back to you. We can help you with all the secondary complications that come with muscle cramps and pain and joint pain and stomach issues, all those things we saw about in the first slide. We can help ameliorate. We can help with equipment and maybe think about things, little tricks and gadgets between our therapists and myself. I'm actually a rehab doc, and our equipment guy who's super nice and helpful. You'll meet him later today as well, to actually be able to, again, be as independent as possible. Because we don't want you to be independent just at home. We want you to be able to do whatever you need to do and be in whatever equipment you need to be in to get to that ball game, or see your grandkid on the field, or your kid in their program, or travel, or anything that is important to you. And I think just to be a partner, I always promise my patients, and I see a wide variety of patients, neuromuscular and not, that I may not always be able to cure what you have. I think that's getting rare in our medical environment, but I can be your partner. I can be here. I can be a sounding board. I can be somebody to hear you, and to do the very best to make your life and your health the very best it can be. And sometimes just to listen, and sometimes we can cry on each other's shoulders, but we're here. And I think, I hope that is important, and is a value to my patients, that they have us. Every member of our staff, every therapist you saw in there, the social worker, that we're here to help you in any way we can. And we do appreciate the MDA being a partner in that, and so that we can have all those services and have our clinic open for you all. This is our team. I know we're not in person and we could meet everybody, but we try to get the best picture we can in COVID, masked or not. Betty is our nurse on the far left. She might be the person you talk to on the phone or helps you with your paperwork. Because she is so busy doing those things, she's not always in clinic. Dr. Pikely is next to her. She's our newest addition, as I said, from Cleveland Clinic. She's a neurologist, board certified, neuromuscular trained. Sherlon is in the back. She's in our clinic. She's our administrative assistant and is always very lovely. You may also catch her on the phone. Beverly Spicer is next. Those of you who are patients may know she has the farm and all the chickens and the donkey, and it's just really a delight. And Cynthia's next to her. She's going to be able to start coming to our clinics now as well. She is really the main force behind our infusions and our new treatments and getting the insurance to approve them and helping with all the hiccups there. And so she is a jewel. Then I'm next, and then Dr. Shukla, who has been with us, oh goodness, almost 2 years now. He went to Harvard and then trained in Miami in his fellowship. He's neurology, board certified. I'm the only physical medicine and rehab, but I did do neuromuscular as well. So I appreciate you listening to me. I hope this was helpful to you. I hope it's helpful to see what we can offer. And if you are a patient, I hope we have been able to live up to the hype for you all.
Thank you, Dr. Witt. Thank you. I do think a lot of things that you spoke about being multidisciplinary, I think that that is one of the things MDA's care centers are really moving towards, is being all-encompassing multidisciplinary clinic. I wanted to, someone had typed in, yes, treating the whole person is vital. And I wanted to ask, if you do see your general practitioner, how important is it to keep that line of communication open between that individual and their neurologist?
Like, how important is it for your discussions with a primary care doctor to be translated to us?
Yes, if that person goes to them to see about an ailment that they might be having, or to be sick, if they do, come down with something, is that communication, does the neurologist need to know exactly everything that they see their GP for, or should the neurologist just be concerned with their neurological issues?
I think it is helpful to know what's going on. I don't think we have to know like every adjustment of the blood pressure medicine, but if they're getting sick, if they're having respiratory complications or they're having heart trouble, then we need to know, because that goes into the whole situation of the illness. I mean, if we got a note once or twice a year about what's going on, the thing I would like to remind patients is that, we do have HIPAA, and so we have privacy acts. And so if you want them to communicate with us or vice versa, please let us know. And if you can say, hey, send this note to my primary, I'm happy to do it. But I do feel like there's a privacy issue for me just to send it all the time.
Okay.
But I think, just let your primary doctor know, hey, send a copy. With our electronic medical records, that's so easy to do. Send a copy to my primary, send a copy to the MDA clinic, and then we're all in the loop of what's going on, and that is helpful.
A question, and I'm not sure where this person is from, but it's a concern, I think, with a lot of folks that trying to get to clinic and trying to get to your appointments and be seen by so many ancillaries to help. Are there any means of transportation that help with funding of getting to that appointment that you are aware of?
Medicaid is the main one. So they will
Okay.
either provide transportation, which I know is not perfect, but it's there, or they will reimburse your mileage if you drive.
Okay.
And so that's not always something I think people are aware of. If they provide transportation, then you usually have to call 3 days in advance or more than 3 days in advance, and they'll put you on the schedule. We'll fill out the forms to make sure that they get you the right car or wheelchair accessible or whatever. I have the forms for the mileage. That's also something a patient has to instigate and get a number, and then we sign a form when they come into clinic. And it's actually a pretty decent reimbursement. It's better. I think it's like I think it's 30 cents on the mile. So it's a little better than they would do just like with taxes or whatever. If you don't have Medicaid, that does get a little more challenging. Yeah, but we do have some telehealth options now, for better or for worse with COVID. I think we'll be able to maintain some of the telehealth options. And that's great for intermediate visits.
Yes.
But if you need a fitting or equipment, that still needs to be in the clinic. So it's, yeah.
Exactly. And just a comment on, or I should say a question that was brought up from someone earlier in an email was, can you have an overdose of calcium when you have muscular dystrophy?
When you have muscular dystrophy, so the main risk with too much, your body will process it.
Okay.
Generally speaking, I mean, 1,000 milligrams a day is about where I would sit on the calcium.
Okay.
If you get too much, you can get kidney stones. So people who are prone to kidney stones would be at more risk for calcium overdose, and I really wouldn't go more than 1,000 a day.
Okay. All right. That's good to know. Let me see. I'm not seeing anything else come through the chat. Yeah, I think that's it. Thank you very much for your time this morning and for a Saturday. So I definitely appreciate it.
All right. Well, thanks to everyone for staying awake.
Thank you.
All right. Thanks, guys.
Up next, we are going to hear from Dana Goodlow, and she is our genetic counselor, and we will begin at the top of the hour. So please stay tuned.